We are live.
We welcome everybody to this World Sight Day celebration program by the All India Ophthalmological Society here today. And we will begin this program with the introductory video. So we begin our webinar today on the occasion of the World Sight Day. The World Sight Day is celebrated on the second Thursday of October each year, and it has been celebrated since 2000. And at the outset, I would like to request Dr. Maipal Sachdev, who is the president of All India Ophthalmological Society, to give his address.
Thank you very much, Dr. Namrata, and welcome all the participants and the delegates for this celebration of World Sight Day on 8th of October 2020. All India Ophthalmological Society, as you all know, is a society which is one of the largest societies in the world, and India also has the problem of the largest number of people who are visually handicapped. So therefore, it is imperative that the All India Ophthalmological Society, as also all the ophthalmologists in India, should rededicate themselves at this particular day to the cause of eradication of blindness. There are various estimates that are there as regards the blindness which is there. As Dr. Namrata said, the second Thursday of every October is being celebrated since 2020 as the World Sight Day. Now, when you are looking at the incidence or the prevalence of the blindness, there are at least 2.2 billion people with vision impairment, and at least 1 billion of these people with vision impairment that could have been prevented or has yet to be addressed. So that means that you can have people come out of or prevented to go into this scourge of blindness to the tune of at least 1 billion people. Now, the major causes of blindness or visual impairment are unaddressed refractive error. Now, this is something which starts from the school, which we need to look at. Cataract still remains the leading cause of reversible blindness that we can do. Glaucoma, corneal opacities have come up, diabetic retinopathy, trachoma fortunately is coming down, and unaddressed presbyopia. So these are a couple of figures which which are there for you to see. But myopia, as you all know, especially also when we are looking at the unprecedented COVID and the lot of use of smartphones and these computers, etc., myopia is tending to increase, and there is an increase in the incidence of myopia across the globe. And that is something because the eyes are not made for near vision, and the amount of work that people are doing on the near is leading to an increase in the myopia. There are drugs or there are methodologies which are being tried, and it is a big global impact that untreated myopia has. Now, if you look at the next causes, you have glaucoma, which is significant, trachoma, which is there. You can look at again presbyopia, and that is the holy grail if we are able to take care of presbyopia. But what is very, very important is that diabetic retinopathy is tending to increase because India, unfortunately, is also the diabetic capital of the world. And given a long enough association with diabetes, especially insulin dependent, there is the possibility of developing blinding complications of diabetic retinopathy. Now, if you look at the next big thing that is happening, the other day we were discussing, the ARMD is tending to go up because of, again, longevity, and the intravitreal injections have come as a relief to us. And the number of intravitreal injections they are saying which are being put today are possibly more than the cataract surgeries that are being done in India. Now, the World Vision Report has said that eye care should become an integral part of universal health coverage. It is important that it is implemented, integrated, and people-centric eye care is there in all health systems. As you all know that there is a rudimentary eye care system in large parts of the remote areas of the country, and people have to travel at distances to get eye care. High quality implementation and health system research complementing evidence for effective eye care interventions is important, and one needs to monitor and evaluate the progress towards these. Also, one needs to raise the awareness, engage and empower the people and communities about eye care. Now, one good thing is that India was the first country in the world to launch the National Program for Control of Blindness in 1976. And the goal was to reduce the blindness prevalence to only 0.3%. In 2013, the World Health Assembly adopted Universal Eye Health, and the global action plan was to reduce the prevalence of avoidable visual impairment by 25% of what it was by the year 2019 as compared to the baseline prevalence of 2010. Now, India has implemented a series of measures in its ongoing national program of blindness, and we have several people who are associated with that who will be talking about that. And I think we are proud of the work that is being done in India and the contribution by the ophthalmologists to reduce this load of visual impairment. Now, cataract in India from the earlier estimates of about 80% have gone down to 66.2%. Corneal opacities and complications out of cataract surgery, these two are tending to increase. So this is very, very important, which we need to look at. And posterior segment problems, which is a diabetic retinopathy and ARMD, these are also increasing. Glaucoma was always there and glaucoma is there, but with the cataract prevalence coming down, the percentage of glaucoma contribution has also gone up. So this is something very, very important, that corneal blindness is something which is tending to increase, which is there. Now, if you look at visual impairment of patients more than 50 years, cataract and uncorrected refractive errors and cataract complications. So these are the three main things for people greater than 50 years. But if you look at patients who are younger, which is less than 50 years, corneal opacity therefore tends to become the highest. So basically, we are looking at two important things, that is cataract in the older age group and corneal opacities in the younger age group. So these are the two differentiators between older and younger people. And visual impairment, as you can see, if you look at visual impairment, that the maximum is uncorrected refractive errors, and that is something which is very, very simple. A lot of states have taken up this under the program of providing glasses to the presbyopic patients, to the older patients, post cataract surgery patients also if required, and the children in the school health program which is there. Now, we have also seen a steady increase in the implantation of the intraocular lens. When we were residents, we started with intracapsular cataract extraction, and patients were given a standard +10, which obviously in today's world is not the thing. But as we have gone along with the national program for control of blindness, these eye camps have been stopped. They have shifted to the base camp approach, where the patients are brought into the hospital, and almost all the surgeries are done with an intraocular lens implantation. And I think, as you all know, we are doing close to 7 million plus cataract surgeries. And if you look at 95%, 94% of them being with IOL, we are the largest implanting country in the world. Europe, US, China put together is less than us. Now, the reduction in blindness, which is very, very important, and visual impairment in the overall population, that is what we are looking from 2010 to 2019. The blindness has gone down from 0.68% to 0.36, and the prevalence of visual impairment 5.3 to 2.55. That's by any standards a good achievement, and we should be proud of it, but still more needs to be done. Now, trends and prevalence of visual impairment 618, less than 618, the better eye over the years, you can again see from 32.3, it has come to 13.76. So there is a decline that is there, which is happening both in the visually blind as also the visually impaired people. So I think a lot has been done, which is there. And the national program is very, very important. This is the survey which was done from 2015 to 2019, where there is a reduction in blindness, moderate severe visual impairment, and visual impairment from the 2010 estimates. So the WHO Global Action Plan for Universal Eye Health targets a reduction in the prevalence of visual impairment by 25%, as I told you, by the year 2019 from the 2010 baseline. And the current survey shows a reduction of actually 47.1% in blindness, which is there. So this shows that the target of 25% reduction in visual impairment has been successfully achieved in India. But we should not rest on our past laurels. I think we need to do more, and we need to actually reduce the burden of blindness to near zero, or to whatever levels that is very, very possible. So I think with this, I will just, we should say that, yes, All India Ophthalmological Society is dedicated to the cause of eradicating needless blindness, and no person should be should needlessly go blind. And we do celebrate the World Sight Day, and several activities have been planned which are going to unfold, including a grand photographic competition. Thank you very much, and thank you for participating in this World Sight Day celebrations.
Thank you, sir, for a very nice overview and a very encouraging message for all of us. Next, we have Dr. Praveen Vashisht with us, who is a professor and head of community ophthalmology at RP Center AIMS, and also the vice president of Vision 2020. And he will be discussing with us about blindness in India, the quantum of problem, where are we? So, Dr. Praveen Vashisht, please.
It needs to be highlighted that Dr. Praveen has been the key person, along with Ministry of Health and Family Welfare and NPECB, who have done a national survey and have shown us that the figures of blindness have, completely changed. So, Dr. Praveen, over to you, please.
Unmute.
Unmute,
Unmute.
Praveen. You have to unmute yourself.
Thank you, Dr. Namrata and Dr. Rajesh. I think Dr. Mahipal has covered most of the things from this survey only, but I'll be presenting it from my perspective. As we know that the goal is to reduce prevalence 0.3, and this target was kept for 2020. And as per National Health Policy, now the target has been revised to 0.25% by the year 2025. And WHO, they had a target for visual impairment. For your understanding, visual impairment, I must mention that it is presenting visual acuity less than 6/18. And in fact, the blindness is also included here in visual impairment as per the WHO definition. And this is the trend of blindness in our country. When the national program was started in 1976, before that, ICMR conducted that survey, and at that time, the prevalence of blindness in general population was 1.38%. All these definitions were as per the previous definition of blindness, all these figures, and at that time, the definition of blindness was presenting visual acuity less than 6/60. In 1986-89, a midterm evaluation of the program was conducted, and we found that the prevalence was reduced, was further increased to 1.49%. And after that, the government of India, under the national program, they had a massive program, mainly a WHO and World Bank sponsored cataract surgical service program. And we could see the impact that from 1.49% to 1.1%, nearly 25% reduction of blindness was there. And in 2007, again, RP Center did this survey and we got prevalence as 1%. So we were saying that in 2007, the total number of blind people in our country were 12 million. This is a figure which have been quoted till last year, 2019. As I mentioned, the definition of blindness is same as WHO definition now as in India. It is now less than 3/60. The Ministry, Government of India, they redefined their definition in 2017. And visual impairment, though NPCB defined as less than 6/18 to 3/60, but WHO also include blindness as part of visual impairment. The national survey was conducted nearly 1,11,000 population, that include 93,000 population above 50 years of age, another 18,000 under 50 years of age. And the report was released last year by our Honorable Health Minister. And that survey included the blindness, visual impairment, as well as prevalence of diabetic retinopathy in the country. You can see the various type of blindness and visual impairment prevalence. It is in 50 plus population. Prevalence of blindness was 1.99%, and overall visual impairment was 13.76%. And this pinhole blindness represent the best corrected visual acuity. It was 1.75%. In fact, I must mention this thing that as per WHO, previously the definition was best corrected visual acuity, and the target of 0.3 what WHO was as per best corrected. I must say, though at present we say in oral population it is 0.36 as per presenting visual acuity, but if we take best corrected visual acuity, we are further closer to 0.3. It is 0.32%. And the blindness is more common among females. In fact, all type of blindness and visual impairment is seen more common among females. It is age related. You can see in 50 to 59, it was just 0.5%. But if we go into higher age group, 80 plus population is 11.6%. Another indicator is the resident in rural population. Rural India, the prevalence is much higher. It is 2.14% compared to urban 1.8%. And see the effect of literacy. Illiterate population, they have 3.23%, whereas the educated population has a very low prevalence of blindness. So you can understand various factors which affect blindness in our country. And this is the district-wise prevalence of blindness from different 31 districts where we conducted this survey. Though the national average is 1.99, the lower prevalence in southern India, in Thrissur, that is in Kerala, Goa, and in Gujarat also prevalence is low, whereas in UP, it is much, much higher. As Dr. Maipal has given this figure, the prevalence of blindness in general population was estimated by us. It was 0.36%, and prevalence of visual impairment is 2.55%. And this slide has been shown by Dr. Maipal. We are very proud that instead of a target of 25% reduction, our country achieved a reduction of 51.9% in visual impairment. That's a big achievement, and I think it's a great initiative by National Program for Control of Blindness, and everyone should be complimented for this thing. Among the causes, the cataract is the leading cause. In fact, since the inception of the program, since 1976, cataract has been leading cause of blindness in our country. In fact, in all the districts where we conducted survey, it was more than 50% of blindness. So we have to give emphasis to cataract, untreated cataract. The another important thing is this non-trichomatous corneal opacity. It was just 0.9% as proportion of blindness. Now it is increased to 7.4%. That means we have to give more and more emphasis on non-trichomatous corneal opacity in our country. Further, the cataract surgical complications. This is another important cause. Previously, it was just around 3%. Now, 7.2% of blindness is due to cataract surgical complication. That clearly shows that we have to give more and more importance to quality of cataracts surgery in our country. Fortunately, the diabetic retinopathy, it is responsible for just 1.2% of blindness. We may have high prevalence of diabetes. We may have high prevalence of diabetic retinopathy among diabetics, but the blindness due to DR compared to other different diseases, it is much, much lower. I would like to present one or two slides about National Diabetic Retinopathy Survey. The prevalence of diabetes in our country, we got 11.9%, that include 8% of the non-diabetics and 3.9% of new diabetic. New diabetic were defined if the random blood sugar is more than 200 milligram per deciliter. And among them, you can see the prevalence of diabetic retinopathy is 16.9% and maculopathy is 7%. The sight-threatening DR, where the national program is more emphasizing, it was 3.6% among the all diabetics. And you can see the prevalence in different districts. The prevalence of diabetes going up to 29%, and prevalence of DR among diabetes is up to 27%. You can see the diabetes is much more common in southern part of the country, southern region, and even DR is much more common in southern part of our country. So keeping all things into consideration, even at this stage, we can say that uncorrected cataract and complications related to cataract are the most important priority under the National Program for Control of Blindness and for every one of us. And second most important component what we need to take care is the corneal blindness. So eye donation program, hospital corneal program need to be given more and more emphasis. Thank you very much. Thank you.
Thank you so much, Praveen, for this presentation, and more importantly, for doing that mammoth work that you have done at RP Center, and for doing the national survey and changing the statistics, not changing the statistics, showing us that the statistics have changed, for the past so many years, because otherwise, till the time that a new survey is done, everybody is led to believe the old figures only, and we don't know, where we are standing. I know it is a humongous task, and we've seen you, working in the community ophthalmology services department tirelessly with your team, which has also done a great job. So congratulations and thank you for your great talk. It is
Thank
now
you.
my pleasure to invite the next speaker, Dr. Pramila Gupta, who's the Principal Consultant, Directorate General of Health Services, Ministry of Health and Family Welfare, New Delhi. She needs completely no introduction. Actually, everybody knows her very well, and she has been the torchbearer, in fact, of the entire ophthalmic program, even when she was DGHS and even much before that. So we owe it all to these people who make policies, who make things happen, and we finally get the results. So over to you, ma'am, for your talk. Ma'am is going to be talking about cataract backlog in India, how to combat it.
Thank you, Dr. Namrata, for giving me this opportunity to talk on strategies for cataract blindness backlog pre-India, as emphasized by a president of AIOS and brought out by Dr. Praveen Vashisht. even though the reduction in prevalence of blindness has been down from 1% in 2006-7 to 0.36%, cataract still remains the leading cause of blindness. And so our strategy has to revolve around how to get this done. In spite of all our efforts and so many our main focus also is on cataract surgery only in the program. But in spite of that, cataract still remains the major cause of blindness. So, आगे कैसे जाएगा? अच्छा. This slide has been shown by Dr. Praveen also, so I'll not go in the details. This just highlights the way the prevalence of blindness in India has gone down due to efforts of all government setups, NGOs, and all partners with us. As already highlighted, among the causes of blindness, cataract still remains the major cause of blindness, causing 66.2% of blindness and even around 71% of visual impairment. So we have to tackle this. Now, what are we doing at the national level? The figures that we get at the national level, we are doing around 64 to 65 lakh cataract surgeries every year. And as pointed out, more than 95% of these cataract surgeries are with IOL implantation. But is this enough? So let us see what is the need for cataract surgeries. So if we take the population of India, today's population, it is around 13,600 lakhs. The prevalence of blindness as per our national survey is 0.36%, which brings out the total number of blind persons to be 49 lakhs. Prevalence of cataract being 66.2%. The total number of the total persons with blindness due to cataract comes out to be 32.41 lakhs. And the incidence of cataract every year, this is 32.41 lakh is the prevalence. But every year, around 38 lakh cases are added to this blindness load. So there is around 70.41 lakh is the case load every year. So if we take the cumulative incidence of 5 years, it will come to around 222 lakhs surgery. And see, in a year, we are only doing 64 to 65 lakh surgery, whereas we need to do 70.41 lakh surgeries. So every year, this will keep on accumulating, and we have calculated this for a 5-year period. And this cumulative incidence is only for the blind people. So if we multiply it 3 times, because of the, if we include the blind cases, the visually impaired cataract cases, our caseload for 5 years comes to around 667 lakh surgeries to be done. And dividing it by 5, there has to be around 133 lakh surgeries annually. And what are the issues besides this huge load of cataract surgeries? The availability and accessibility of eye care services is more in the urban areas, less in the rural areas, whereas what we need is more services in the rural areas. Then there is ignorance and religious beliefs due to which people don't come forward, fear of surgery, and gender bias. As Dr. Praveen showed, cataract is more common in females, but generally the cataract surgeries being done are lesser in females. So this is a double whammy for the females. Then, of course, inequitable distribution of HR and infrastructure and varying CSR among district and states. And of course, lack of training and interest among government ophthalmologists. So this is a highly daunting task, but I think with proper planning and strategies in place, we can take it up and get rid of this cataract blindness backlog and make India free to only do the incidence that occurs every year. So this is to be done in a mission mode of 5 years in a phased manner. In the first phase, that will comprise of 2-year period, we'll do mainly blind and severe visually impaired people. That is around 162 lakhs in a 2-year period. Of course, some moderately visual impaired patients who will come will not refuse them, so that they will be included. In phase 2, in the next 3 years, mostly moderate VIs will be done, which comprises of 504 lakhs, and our total burden will be covered by this. Of course, the commitment for this mission mode will have to be at the highest authority, both at the national and state level, along with a very strong political will. And each state will have to assess the current magnitude of cataract blindness, as well as the services available at the district level where cataract surgeries occur, and prepare a state level and a district level plan so that a gap analysis can be done. And based on this gap analysis, each state and district will have to work towards improving infrastructure, equipment, and providing HR for the cataract surgical services. And of course, creating awareness in the community to generate the demand for cataract surgery is a must. Then what at each level, what we need to do is we have to utilize the ground level healthcare volunteers to screen and record the cataract blind and visually impaired cases at the community level, and undertaking cataract surgeries in a mission mode duly involving government, NGO, and private sector. And these operating units will have to be allocated specific areas, that is blocks and regions, so that these surgeries can be done. Another issue that Dr. Praveen and Dr. Mahipal both had highlighted was the quality of cataract surgeries. So we'll have to maintain quality of cataract surgeries and giving preference to blind and severely visually impaired cases due to cataract, and our referral services for any complications, sight-threatening complications from secondary to tertiary care units. These referral linkages will have to be developed and strengthened. And another strategy that the government is mulling over, and it is in a development phases, to incentivize the states to achieve the status of being cataract backlog free. And we are thinking of incentivizing them through monetary and non-monetary awards. Of course, the criteria for selecting the district or the state for the award would be based on qualitative as well as quantitative assessment by an independent evaluation team or a third party. Only after that, these awards will be given. So criteria have been developed. We have submitted to the government, and I hope this will start soon. And this will be a big incentive to do the cataract surgeries in a mission mode. Now, the various levels will have roles to play in this. At the vision centers level, identified blind cases by ASHA or the health volunteers will have to be checked whether the blindness is due to cataract or any other causes by our PMOAs and optometrists. The other causes can be dealt with by the PMOAs or referral to a tertiary center. The cataract cases will be listed and line listed so that we know each village wise the register will have to be maintained, and a date wise, patient wise operation schedule will have to be prepared, and this will be monitored in consultation with the district ophthalmologist. And PMOs and ASHAs will be responsible to send these patients to the cataract surgical centers and later on for their follow-up. Now at the district level, a detailed mapping of the state program officers will do a detailed mapping of available locations for surgeries and making a district level plan. And of course, this will have to be integrated in the MIS application, because all cataract surgeries done will have to be uploaded on the MIS application. And capacity building of available HR will have to be done at the district level. A broad-based society will have to be made to do this monitoring and district level action plan. And a district will declare itself cataract backlog free once all the blindness cases in the district stand operated and an independent team has counter-checked for the same. And as told, all data will be uploaded on the IT platform in a transparent manner. And of course, a national level IT application will have to be created for monitoring, evaluation, and strengthening and capturing the patient feedback also. That will have to be an integral component of the application. And to ensure transparency, all patient details will be captured, pre and post surgical details, and geotagged. Photographs of the patient also to be captured. Funds to the NGOs, private practitioners, as well as hospitals will be released online, preferably directly through the states. So this is what we envisage End slideshow. Thank you. Thanks a lot for patient hearing. And this is our strategy for developing a cataract blindness backlog free. Thank you.
Ma'am, thank you, ma'am, for enlightening us with the wonderful strategies in order to combat cataract blindness. You have always been a great guiding force, a great support for for us, particularly whenever we have to do any community-related, any health-related, project. Whenever we do, you are always a great help. Thanks for that, ma'am. Before we move on to the next speaker, I can see we have Dr. Lalit Verma, who is the Vice President of AIOS, and he's with us. We would like to have his comments on this occasion of World Sight Day.
Thank you, Rajesh, for asking me to say something, but I am so happy that AIOS is doing this special program on this World Sight Day. You see, all of us in some way contribute to doing our bit for for some blindness relief activities. But world over, I think this is still a minuscule, whatever all of us do. I think this webinar or series of webinars, I know so a lot of webinars are being held today, will further, motivate all of us, all the members of AIOS, to do so much more what is desired in all the fields of cataract, cornea, and I know AIOS has drawn up a huge plan with the speakers from across. I just heard Dr. Promila, Praveen, and Dr. Sara. So many people are there. They will enlighten us what more needs to be done. And believe me, miles to go before I sleep is very true. And we will, leave no stone unturned to achieve this mission that nobody should needlessly go blind for the want of human interference. So this is what I thought I'll share with you, and all of us will strive to, work hard and try to eliminate all avoidable blindness.
Thank you. Thank you so much, sir, for those words of wisdom. And we also have Dr. Arup Chakravarti, who's the editor proceedings of AIOS. And I would ask him to just say a few words on this World Sight Day.
Thank you, Dr. Namrata, for asking me to comment on the deliberations today. At the outset, I would like to thank AIOS for envisaging on such a beautiful webinar, the lovely theme. And I would like to congratulate Madam also for the very meticulous talk with a lot of data involved in the presentation. And she has presented a good timeline of activities and reward system and all that, which is marvelous. But I have a question for Madam. Now, now that we are going through a difficult period of time, in fact, I also wanted, my hospital started about a year back, and we wanted to participate in, a lot of outreach programs. Everything was charted out, and now things have gone for a toss. So how do you think when we'll be getting back into the groove and ensure that, we rejoin the particular timeline at some point of time? So what do you think we should be doing, and when should you do it?
Dr. Arup, that's $1 million question. Actually, COVID-19 virus is a very complex and paradoxical virus. Nobody knows what havoc it can create, how long will it take to settle down and come, and this pandemic will finally settle down, because till the pandemic is there, this mission mode cannot be started also. So
The timeline has to be reset, I think.
Yes, definitely, sir. Because see, surgery can be done, but not in this mission mode in these times. So definitely we'll have to think of, and at present we cannot even set a timeline because we don't know till what time this pandemic is going to remain. So we just keep our fingers crossed and hope it will soon settle down for us to start this mission mode. Thank you.
Thank you, Madam.
Thank you, Dr. Arup, and thank you, ma'am. And Next, I would like to invite the Dynamic Secretary of AIOS, Professor Namrata Sharma, who is the professor in the field of corneal and refractive services at RP Center, AIMS, and the General Secretary of AIOS, to speak on corneal transplantation and eye banking, the way forward. Professor Namrata Sharma, please.
Thank you, Rajesh. I'll be talking to you about corneal transplantation and eye banking, the way forward. Both eye banking and corneal transplantation has taken a huge hit, especially in the COVID times, and it remains to be seen how we are going to come up to the levels where we were before. As has already been highlighted, that corneal opacity in the new survey has jumped up in the hierarchy, and earlier it used to be much lower as far as the cause of blindness is concerned, but now it is the second commonest cause of blindness after only cataract. And if you look at 0 to 49 years, then it is the first commonest cause of blindness in this population. And this is a population which is, really has a lot of man life hours and is also very productive. So this is a thing which is a cause of concern. This figure, I think, will also change with Dr. Praveen Vashish's survey. And corneal blindness, earlier we used to say is 1% of the total blindness, but now it is much more. There are 760 institutional members or eye banks and eye donation centers, so that has not changed. It remains same, but only out of this, 250 are the ones which are active. That also remains the same. And about 15 eye banks, that is 2%, more than 80%. Can we mute the other speakers, please, admin? And 4% of the 760 organizations can be classified as only full-fledged eye banks. So if you look at the zones, it is the south zone which gives you the maximum number of eyes, followed by the west zone, then followed by the north zone, and then central zone and the east. So central and east is something which really needs to buck up. On 8th May, we were allowed to resume HCRP as per the Ministry of Health and Family Welfare, and that was done. And on 19th August, the voluntary eye donation it was said that from the containment zones, voluntary eye donation cannot be done, and corneal transplantation surgeries can only be done for therapeutic purposes. So we've been pretty much following the same, and these guidelines were circulated by the Eye Bank Association of India, the AIOS, the Cornea Society of India, and Indian Society for Cornea and Keratofractive Surgeons. In the various time periods, we did come out with version 1, version 2, and version 3, and these were published in Indian Journal of Ophthalmology. And it is mandatory, it is not mandatory, but it is at the discretion of the medical director that you take a nasal swab from the deceased donor for RT-PCR before taking the corneas. It is important that training is given in terms of the PPE, how to wear it and how to do doffing and donning to the eye bank staff. Then each eye bank should monitor and consult local THOTA, NOTO, SOTO, ROTO, etc. before taking any policy decision, and instructions of the state government have to be followed because eye banking is a state subject. I think exclusion criteria, like for any other thing, if it is tested for positive COVID-19 or there's history of fever or respiratory illness or conjunctivitis or CT scan shows ground glass opacities, those donors are not taken. These COVID-19 symptoms are embedded in our brains now for the last 6 months, and I don't have to, again repeat this. And this is the algorithm that we follow. If there is a slightest hint that it could be COVID-19 or COVID-19 contact, we assess clinically and we screen, and we do not take the donor cornea for corneal transplantation. But if the screening tells you otherwise, it is negative, and we have a COVID report which also tells you otherwise, then we can proceed with the donation. It is again recommended that we don't take the complete eyeballs, but prefer to take the corneoscleral rims, and cortisol and long-term media, intermediate preservative media have become more commonly used. Double contact povidone iodine solution for the corneas to be taken. Again, general functioning guidelines remain essentially the same. Wearing of the N95 double-lead masks for retrieval of the eyes, along with the use of the sodium hypochlorite, surgical spirit, alcohol wipes, etc. After recovery, and repeat it even at the eye bank. and forms and documents to be exposed to UV light in the laminar flow hood, technicians to wash their hands repeatedly, Arogya Setu to be loaded onto all the eye donation counselors' phones, and limited movement. Everybody is kind of on call and there is hardly any movement. Housekeeping protocol has to be followed. And apart from this, the social distancing has to be followed. The staff is being trained in all the eye banks in a newer fashion so that they get accustomed to the new normal. This is about doffing and donning of the eye bank staff and training thereof. Uh, on 8th of September 2020, the Ministry of Health and Family Welfare and the NPCB came out with the guidelines, standards of eye banking in India 2020 after almost 11 years. And this was a landmark. And again, we would like to thank the Ministry of Health and Family Welfare, particularly Dr. Pramila Gupta, for bringing this out in black and white. And this was a collaborative effort of Vision 2020, Eye Bank Association of India, NPCB, RP Center, IAPB, as well as SightLife, along with the Ministry of Health and Family Welfare. The collection has been quite dismal. We are down by almost 78 to 82% as opposed to the collection which was there last year. And if you look at the tissue distribution, that is also down by 82%. The number of corneas collected are very dismal. You can see 2,754 and 144 in June. Again, the transplants likewise has suffered a lot, and there's been a 93% drop in the number of transplants. Only therapeutic transplants are being done, and this is again to show the figures of 2019 and 2020. We did a survey, and almost 52% of the people felt that we'll come back to normal after 6 months. The preservative media now most often used is cortisol. Earlier it was MK. Again, the transplants figure are dismal as per the EBI survey. The special training of the eye bank staff is completed in almost 80% of the places. The voluntary attrition of the staff has also occurred, and that has happened in 7% of our eye banks. None of the eye banks have taken eyes where SARS-CoV-2 was positive. The nasal swab testing is being done only by 40%, and 40% are still not doing it. COVID testing for the recipient is also the same figure, 40% are doing it and 37% not doing it. Teleconsultation is the way to go, so it has increased by 68%. Then the reservation by the eye bank staff to work in the ongoing pandemic is of course there, but like I said, the attrition, we have managed to still convince the staff, and the attrition is less than their desire not to work. We've managed to convince some of them also. Then this is the decrease in the number of transplants from April-June 2020 vis-a-vis April-June 2019, and it has decreased quite a bit. And we really don't know when this is going to pick up. Therapeutic keratoplasty decline has also occurred to the tune of 82%, but which goes to say that even for emergency surgeries now, the donor corneas are not available. So we are ready, our staff is ready, but I think I would again request Madam Dr. Pramila Gupta today in the newspaper has also shown that our graph now is dipping down, and if it does, to please allow collection of the donor corneas from the voluntary eye donors after excluding out COVID-19 in those cases, because there are a lot of requests from all over India to do so. So our corona warriors are ready, and in fact, it is very surprising to see the enthusiasm some of them have to collect the eyes despite corona. And patients are waiting for the support of everyone, including the donors, and now I would say also the policymakers in the government. So again, a request to the Government of India and Ministry of Health and Family Welfare to please look into this matter. Thank you very much for your kind attention.
Thank you, Dr. Namrata, for a very nice and comprehensive information that you provided to us regarding the issues that we are facing these days, and very rightly pointed out that perhaps once the voluntary donation will start coming, then and once it is allowed, then perhaps the situation may improve. So thank you very much for a very nice presentation. And before we move on to the next speaker, if we can have comments from one of our GC members, like we can have Dr. Chitra Ramamurthy, who can give us the message on this occasion of World Sight Day. Dr. Chitra Ramamurthy is the chairman of Academic and Research Committee of AIOS.
On behalf of the ARC of AIOS, my very special appreciation of your conceptualizing this World Sight Day celebration on a webinar, even in this pandemic. World Sight Day reflections, as I've heard and I've understood, tells us about a significant trend in improvement of blindness control in our country. Without repeating the statistics, we realize that there has been a major drive in different segments of blindness control, that there have been more scientific measures and protocols evolved in significant measures. Essentially, what we all realize is that the awareness has set in, and thus searching out the issues in greater depth itself is the way forward. I realize it's very impressive that every state, city, even rural areas are driven towards the same, going by the percentages. And we see how measures continue to improve even in this pandemic times, with a greater drive towards precautions and vision safeguards. I truly believe that India is on its way forward, and let's hope and wish that we remain cohesive in our efforts to drive blindness out of our country. Thank you.
Thank you. Thank you, Dr. Chitra. And now we invite Dr. Sara Varghese, who is the National Director and Managing Trustee, Sight Savers, and Regional Director, CBM India, to give her talk on disability inclusion in eye care. Dr. Sara Varghese, please.
Good evening. First, let me congratulate All India Ophthalmic Society for conducting this webinar on World Sight Day. I really think it's a very creditable endeavor, and thanks to Professor Namrata Sharma for inviting me as well, and all the organizers of this meeting. The breadth of topics covered is also very interesting, and I'm very honored to speak to this great audience of All India Ophthalmic Society. I'll talk about a slightly different issue as to those who are left out in eye care. From Dr. Promila's talk, we heard that there are still 49 lakhs of people who are blind in India. And while we have great technical advances, we also need to think about what is keeping people from accessing eye care, and how can we make our eye care more inclusive so that no one is left behind. I will particularly focus on the needs of people with disabilities. Perhaps some of you think that this is a very niche area. This is a small number of people, and it doesn't really matter, make a big difference to the statistics. Leaving no one behind inclusion means that everyone benefits from eye health services, including all marginalized groups. We've talked about women. We need to talk about tribal populations, caste-based exclusion, and the exclusion of people with disabilities. The number of people with disabilities is increasing. We are all aware that aging increases the risk of experiencing a high population with non-communicable diseases, diabetes, hypertension. This can result in disability. Poverty is closely associated with disability. And while the Indian census 2011 showed only 2.2% of the population with disability, according to the World Report on Disability, 15 to 18% of the population has disability in India, and disability can affect everyone. So people with disabilities need access to general eye health services like everyone else. All too often we think we are treating people with blindness. What else do we need to do? Or we are preventing avoidable blindness. we also need to think about those with other disabilities who need access to eye health and general health services. And some people, while everyone needs general eye health services, some people with disabilities need specialized eye health services, including referral to rehabilitation or educational opportunities. At this point, I think talking to a primarily medical audience, it's important that we realize that the current model of disability is not a biomedical model, where I think from our medical training, we all think of disability as something, a disease, an impairment in a function, and a problem with a body structure. But the social model of disability includes the aspects of restriction of activities and participation because of barriers. And these barriers may be environmental or personal. So just to illustrate, it is not just about a person who has a child, say, with a retinopathy of prematurity, who has an impairment, a difficulty in functioning of his eyes, but because of the impairment of the body function, there's impairment in movement, there's restrictions in the child going to school or participating, or as I'm going to talk further, in accessing healthcare itself. I think this is what we think of when we, as ophthalmologists, when we think about disability. Or are there conditions or syndromes where there are multiple impairments? So we are aware of rubella or Alport's or VKH, in which multiple impairments may be there. But when studies have shown from India that when they looked at people with visual impairment, 25% also had hearing impairment, 15% also had a physical impairment. And when we come to think of it, as we are dealing with the elderly, these figures begin to make sense. How many of our patients with cataract have hearing problems or difficulty in mobility? Visual impairment can also increase the risk of becoming physically impaired, and it increases the risks of accidents. And studies in Vietnam have shown that cataract surgery actually reduces the risk of having injuries. And it's important to be aware of physical limitations and prioritize patients for cataract surgery as soon as appropriate. People with visual impairment can have mental health problems, and mental health problems, while all people with disabilities have more mental health problems, people with visual impairment are twice as likely to be depressed as those without visual impairment. Children with learning difficulties or adults with learning difficulties very often have visual impairment as well. And sometimes these aspects are forgotten, or they become of lower priority. So people with disabilities face challenges when accessing health services. Attitudes and stigma are very important, and the quality of health services offered for people with disabilities is often insufficient. They may face attitudinal barriers, especially children with learning disabilities, adults with mental disability. They feel, why do they need to have eye surgery? There's a communication barrier. There's barriers in physical access, besides what we are aware of, the affordability and availability of services. The World Report on Disability, 2011, reported that people with disabilities were twice as likely to be denied care and could not afford care. These next two slides say the same things, just in a more pictorial way, and I won't spend too much time on them. But then how do we define inclusion? We need to ensure eye health programs are inclusive of people from all disability groups, including visual impairment, and that people with permanent vision impairment access their rights to wider opportunities. When we talk of accessibility, the typical answer is build a ramp, but very often we don't think about whether the ramp is actually accessible. Accessibility goes well beyond ramps. Is there at least a washroom or a toilet which is accessible for everyone? There's access to information. And this is both written and also oral communication for those with hearing impairment who may need sign language interpretation. The access to services and low vision services is something which is extremely poor in the country. We are happy that we are partnering with RP Center to try and improve some of this, not just in the capital, but across the health network in the country. People with disabilities need access to assistive devices, which may be just spectacles or low vision aids, but also the other devices they need. And there need to be referral systems for people with disabilities with permanent visual impairment to get to education from the eye health organizations, to get into inclusive education or get into employment. Finally, one aspect which is often forgotten is counseling. Counseling starts in the eye care institutions for those who cannot be helped any longer by our medical interventions. This is a brief checklist for inclusion in eye health and covers the points which I already talked about. I'm aware I've taken a few extra minutes, so I will not read them out. And thank you very much for your attention.
Thank you so much, ma'am, for your talk and for your presentation, and for dealing with such a difficult situation, because I think this part everybody forgets. We know about treating, we know about medical management, we know about surgical management, but we don't know what to do when there are no medical or surgical solutions to a problem. So thank you so much, and thank you so much for agreeing to be with us. Dr. Praveen Vashisht is there. Dr. Praveen is doing a lot of work in his department, community ophthalmology, in this aspect. So will you like to tell us something about it?
Sure, Dr. Namrata. In fact, we are very thankful to CBN that they have given us opportunity to actually work for low vision care as well as the rehabilitation. In case of rehabilitation, the Community Ophthalmology Section RP Center, we are actually involving in counseling of patients who are actually coming to RP Center for low vision services. The best part, what we have done is we have done a kind of partnership networking with nearly 76 different organizations who are working for low vision rehabilitation in Delhi and NCR region. And that also include near 33 school for the blinds, where we every week we go there and provide a kind of rehabilitation services. We make disability certificate for them. Plus, a lot of training events have been organized in our department for mobility training and also training in using mobile phones for visually impaired. And beside this, I'm happy to say that we have taken initiative in order to train various RIOs in our country so that they should also have low vision as well as rehabilitation services in their institutes. And in this, I must thank Dr. Promila Gupta also that from ministry side, she has taken a lot of initiatives. Now RP Center is, we can say, it's a low vision rehabilitation training center for the country. Thank you very much. Thank you.
Thank you, Praveen. And I would also like to thank Praveen for helping to coordinate this program, all the talks and all the speakers. I would now request Dr. Sandeep Bhutan, Global Technical Lead, Health Asia from the Sightsavers, to give his talk on novel approaches for delivering primary eye care to the rural underserved Sightsavers experiences through the pandemic.
Thank you, Dr. Amrita, and I thank the entire organizing committee for giving us the opportunity to present our findings or our experiences to this esteemed panel. So just to give you a snapshot of Sightsavers, we are an international development organization working across 34 countries in Sub-Saharan Africa and South Asia, with the aim of kind of relieving the world from avoidable blindness. And we also work in the area of inclusive education and social inclusion. So in the current strategy period, which started from 2015, we have had major successes in working in 8 North Indian states. We've supported nearly 14 million screenings, 1 million cataract surgeries, 3.5 million school screenings have been done, and close to 250,000 truckers screened. So it has been a lot of success that we have seen around. But as speakers before me, Dr. Professor Maipal, Dr. Pramila Gupta, as well as Dr. Praveen have mentioned, the global burden of disease, global burden of visual impairment that is still quite high. But as Dr. Sara also highlighted, that even before the pandemic, the section of this community which were most vulnerable, the women, the elderly, people with disabilities, ethnic minorities, indigenous people, was still quite deprived of services. And the report highlights the need for the hour is a twofold need. One is integration of service delivery models. Another one is people-centered designing of programs. So essentially around people-centered demand generation. The conventional model for Sightsavers and all other organizations working in this sector is pretty much a linear model. We have the clinical partners, which is either government hospitals or non-governmental eye hospitals, and we have the community on the other hand, and then we have linkages between them, which are in the form of health workers, community mobilizers, and organizations like Sightsavers provide the role of monitoring, planning, advocacy, and quality supervision. But the pandemic has kind of made us think differently because there are challenges. Revision in healthcare norms, the fears and aspirations of not only the staff, but also the communities at large, changing priorities at different stages, and reallocation of resources to others. And it has led to, in fact, widening of these inequities. People who are being ignored earlier from general programming are further removed from these programs. So these are the challenges that have come. But wherever there is a challenge, Indian healthcare and Indian population itself has the knack of finding opportunities. So this is an opportunity where newer designs are being implemented, and this integrated people-centered eye care, primary eye care, is now more than ever relevant, and how we can use that in general health programming or eye health programming is something that Sightsavers kind of experimented with in our programs across the 8 states and 72 partners that we work with. And these include 36 government hospitals, government districts, where engagement with the Ministry of Health is very strong, and we work directly with the district hospital and other areas. So the principles that we applied to design these are around the people-centered program is starting a ground-up community ownership of the whole primary care phenomena, where the people and organizations at the ground level are engaged directly in the decision-making, planning, and implementation of primary eye care, engaging with them at all levels, active participation, and communicating with them in all aspects, so that the equity of the design can be maintained. Also, some innovative designs had to be kind of implemented, participatory engagement or designing of these activities, innovative ways of training community health workers or volunteers, creating awareness methods within the sphere allowed through the pandemic, and also innovative ways of screening people, which have to be designed because of the conventional methods like the camps and all were not possible. So how did it evolve? First of all, we've started to engage with the community organizations, the CBOs, the community-based organizations which are on the ground, which have networks deep into the community, who usually work in areas of community empowerment, women empowerment, livelihood. And these organizations have community volunteers who already are working in that sector. And even during these pandemics, these organizations have kind of held quite strong ground, and we tried to engage with them and see how we can use them to deliver the community, the community component of the primary eye care, and then link it with the clinical partners, both the government hospitals and the NGO hospitals, to make sure that the cycle of care is completed. And we are especially focusing on reducing the inequity during this phase. The intervention that have happened start from creating awareness on the go, where conventional methods of outreach camps were not possible. Wherever opportunities arose, we used various platforms to provide healthcare messages. So we know that print media has not provided a lot of benefit in terms of awareness, but it does tell them about the do's and don'ts of what to do during this pandemic. And if they want health eye care, what all can they do and where all can they go? We've used other platforms like the group meetings of self-help groups, which are being organized during this period. We've engaged with them and introduced the method of eye health within them. So this is what we call the community convergence models through our inclusive education programs and social inclusion programs. We work with a lot of these community-based organizations, and we've used that to engage messages. We've used multiple opportunities to create mixed messages or providing messages which are both for education, for pandemic, as well as for eye health. So these opportunities have been used to create awareness, taking the primary care right to where people are. This is a scene from the tea gardens in Siliguri, where we work. So we actually had to go down to the tea gardens where tea workers are working, and all our staff for the community volunteers went there and did the screening there, so that these people are not deprived of the eye care. Taking healthcare directly to the homes, we had to do primary screening at the doorsteps because camps were not possible, and these regions are completely deprived of any kind of structures of primary eye care. So we had to actually take primary eye care to the doorsteps of people by screening using community volunteers and other health workers that we had. Also, other professional body occupations like truck drivers, we have been screening them before also. So directly doing the screenings where they are performing their responsibilities and still maintaining all the social distancing norms and the sanitization norms that were required. Home healthcare has become a norm in urban health form setting, but to take that concept and apply that to primary eye care is something that we've tried. And we know, you can see from these photographs that these people would have been otherwise completely missed out. They would have been waiting for outreach camps, which are not happening, and would have led to disasters for their vision and outcomes otherwise. So we went directly to that. But in that sense, we have strengthened the existing PHCs and CHCs where eye cares have been established. Fixed facilities have become the center point of delivering primary eye care. Also combined with them are smaller groups with distancing norms where eye care can be provided sustainably and more carefully. This is the necessary equipments, processes, and people changes have been done as per the guidelines issued by Ministry of Health, as well as bodies like AIOS, to make sure that the risks are kept down and still we are able to provide the necessary services to people through the primary eye care systems that have been created. We are using some innovative technologies like the vision screeners for children, particularly when schools are closed and we're not able to do the conventional school screening. We are trying to use technology to deliver primary vision screening at the doorsteps where children are living and make sure that they're not deprived of the refractive care or other things that are required. Services, essential services like refractive pair of glasses, basic primary eye care, the basic medications or basic treatment for common eye conditions like infections had to be delivered right at the doorsteps or at least at the closest point. And these have been still sustained through the pandemic also, with taking care of all the precautions for preventing spread of the infection. During this phase, it was also very important for us to maintain very good quality data so that we know which kind of strategy is working, where do we need to kind of apply more emphasis on. So maintaining very stringent data so that compliance monitoring can be done and we can understand the effectiveness of these practices to close the loop and make sure that people are getting the kind of care that they get. So as highlighted by Dr. Pramila, we've also been trying to create this community-based mechanism where the volunteers or existing ASHA workers or other community-based agencies can be kind of empowered with the knowledge and skills to go door-to-door providing messages, as well as doing this kind of screening, and people can be tested, and those who fail are then kind of linked to existing facilities We've heard from our government as well as non-governmental partners that they're very keen to provide services, but the patients are not coming. We connect them with these services so that people are brought for care. And also the post-operative compliance can be monitored so that this incidence of post-operative complications can be reduced and can be tracked. Thus, some of the experiences that we have finalized is that the fixed facility model is going to be the future of primary care, and the outreach ones probably will need to replace vision centers or strengthen PHCs or CHCs, or as Dr. Pramila said, around the health and wellness centers where structured primary eye care can be delivered. Engaging with existing community structures like the CBOs is important, and that's going to be a strength that we need to utilize. Door-to-door screening wherever possible, wherever can be done safely, is being conducted, and that has led to prevention of cases would have otherwise gone blind, and linkages with other social and development aspects so that we can focus on the most vulnerable, and the inequities that are already increasing can be reduced as such. So as I said, we shouldn't let a good crisis go to waste. And this is the time when we use this crisis to rethink about how to deliver primary eye care through this pandemic and beyond, so that people like her are provided the right kind of care and still have hope in sight. Thank you.
Thank you so much, Dr. Sandeep, for that wonderful talk and wonderful overview. Dr. Partha Bishwas, who is the Chairman Scientific Committee of All India Ophthalmological Societies, with us here today, and he's done a lot of work, I know, on screening on diabetic retinopathy as a primary care procedure. So, Dr. Partha, would you like to say something about that?
Thank you very much, Dr. Namrata, and it's a great opportunity to be associated with so many people in this webinar who are doing such great work. And when we were in the ARC did the large project of finding the missing link, and this is what we named the project, and it was a pan-India project in which the diabetic retinopathy that we all have assessed in our small places in different locations, and the studies that have gone, most of them have targeted the population of diabetics who have come to the ophthalmologist, and the amount and the quantum of diabetic blindness was assessed at the ophthalmologist clinic. But there was a very large number who do not come to the ophthalmologist clinic, but they very regularly go to the physician's clinic and to the diabetologist clinic. And it's unfortunate that our colleagues, diabetologists and physicians, do not refer, or even if they do, a very quant number come to the ophthalmologist clinic. So we wanted to find the missing link that there was, and the number of the patients who were afflicted already with diabetic retinopathy but had not come to the ophthalmologist's clinic. And we went on a survey, and we did the survey in the rural as well as in the urban parts of India. In 12 states, we conducted this survey, and we came up with great results. We are in the process of publishing these results, and they will be very big eye-openers, and a lot of things that can be done, and it would definitely take a big step towards addressing the need of this part of needless blindness that the diabetics actually harbor and are not able to be treated by the ophthalmologist because they do not come to our clinics. So having said this, this again is a very, very important aspect, and we being in the center of the diabetic population and going to be the diabetic capital of the world in the near future, we need to take very strong steps and measures on this. The pandemic, of course, has really pushed back this project a little, as well as the difficulties of addressing the larger population of diabetics are definitely has taken a back step now. But with the rolling of the services which is coming on, I'm sure that we'll be able to forge ahead. And I would request all our ophthalmologists, our colleagues, to try and form a proper link with our physicians and our colleagues, our diabetologist colleagues, so that the number of patients that we actually can address can go up, and we'll be able to see these diabetic patients at the early stages of diabetes and treat them before they actually become blind because of diabetic retinopathy. Thank you very much, Dr. Namrata. Thank you for the opportunity.
Thank you, Dr. Partha. And now I would request Dr. Rishiraj Bora, Country Director, Orbis International, to give his talk on refractive error among children, the REACH program, which is an innovative school eye health program.
So good evening and a very happy World Sight Day to everyone. I'd like to thank AIOS Secretariat, especially Professor Namrata Sharma, for giving us this opportunity to talk about our work in refractive error among children. Share the screen. Yes, and this 2020, although we have this pandemic around, but Orbis has completed 20 years of services in India in 2020. We started our work in 2000, and then we completed our work, completed 20 years this year. Our basic focus have been for last 20 years is around childhood blindness and then prevention of childhood blindness. When working with several partner institutions in India, we have established 33 children's eye care centers across 17 states in India. So many of the speakers, Professor Sachdeva, Dr. Pramila, and Dr. Praveen has reiterated that this refractive error is one of the key problem now in terms of visual impairment. And we have taken up this issue, although we have been doing the refractive error programs in our last 20 years of children's eye care program in India. But we have found that there are a few things that are not being addressed in our work earlier, and then we need to relook at and then think a little differently to deliver refractive error services to children. So we created this program called REACH. 80% of what a child learns is visual. And these two important studies were conducted in 2002, when 81.7% urban children population is visually impaired due to refractive error. In rural, it is 61%. And approximately 33 million children need refractive error services in India. And this entire problem further complicated by the statement like half of the world will be short-sighted by 2050. So we had to do something. And then, apart from school, which is the best place to start a refractive error control program for children. So we started this program called Refractive Error Among Children with the support from Qatar Development Fund in 15 districts of India in 8 states. I'd like to talk about this process a little more. This is important because normally what we did earlier and what are the changes we have made here. So this process, I'd like to explain about like the planning of delivering refractive error services to our partners. The planning and preparation was the most important thing, just to identify the schools in the catchment area and then getting all the student database before we get into a primary screening. We have a trained team in primary screener. We use the 0.2 logmar from 3-meter distance. When you go to the school, there are 4 categories of children were identified. One is the group who cannot read, the child who cannot read 0.2 logmar. That is one group sent to the secondary evaluation. Second is the child who can read 0.2 logmar, but also can read plus 1.5, also referred to the secondary evaluation. And then the children who are wearing spectacles, they are also referred to the secondary evaluation. And then anyone who actually complains about any eye problems or any difficulties, they're also referred to the secondary evaluation. In the secondary evaluation, trained team goes to the school and then they do the detailed evaluation. And the children who has refractive error needs refraction is done, and then prescription is provided. When the prescription is provided, after exactly 2 weeks, we deliver the spectacle to the kids. And then after exactly 3 months of delivery of spectacles, we go back to the school and then see whether children are wearing spectacle or not for, we call it as compliance visit. During the compliance visit, our compliance definition is if the child wearing the spectacle, even if it is not in the, with the child, but they're not wearing spectacle, we put it as a kind of non-compliance. So that way, after 3 months, when the compliance is done, during the compliance also, one thing we try to figure out that now there are a lot of barriers. We know why they don't wear spectacle, but the enablers also we would like to identify during the process. So there are 2 questionnaires. If someone is wearing spectacle also, we have some set of questions, and then we ask them and I gather some information to know why they are wearing spectacle. Other group who are not wearing spectacles, as usual, to identify the barriers, we collect that information from them also. So once that is done, exactly from 1 year from the primary screening that we did in that particular school, we go back again and then do screen and look at a particular select group of children, those who were undergone the secondary screening last year. Entire group of children were screened again during annual follow-up. The other group, which actually has other eye problem than refractive error, they're sent to the hospital for say surgery and other for further evaluation, and who needs surgeries and who has got other problems that needs other treatment, they're referred back to the hospital. We created a mechanism to track these referral cases through a referral compliance mechanism. And then when we have the annual follow-up, during the annual follow-up also, we include this particular group to see that now how they are doing. So this is what the entire process is. Originally, earlier process was like, once we give the spectacles, the entire school health, school screening programs ends. But we would like to, through REACH, we would like to close the loop and then see that whether the compliance is one of the key things that we would like to address through this particular process, so that we can see that what benefits out of our intervention the child is getting. So this is the process, and then what is the difference? Earlier it was screening, and then now it is comprehensive eye examination, including sacroplasia also done wherever it is needed. Spectacle prescription and dispensing. From that, we do compliance of spectacle wear. There was a one-off event earlier. Now every year we go back. Why we go back? I'll show you a few data at the end of the presentation. It was paper-based earlier, and then now it is digital, because this we collect all the data through a software called ReachSoft, so that we can analyze this data and then see that now where the program strategies need to be changed in future. So it was a unique approach for each organization. We standardized some of the approaches by developing standardized guideline for an entire program. Then standardize the hardware also, and then collect all the information in a software called ReachSoft. So this is a large-scale innovative highlight of this particular program is large-scale innovative model. We completed a large pilot, 5 million screening were done in 3 years. And it's a technology-enabled program. All steps of the planning, implementation, and program management done through the software. And the data were collected through the system. It provides a lot of information, and then it creates a lot of knowledge for us. And in future program, whatever needs to be changed with the data analysis, we're trying to do that. Interestingly, the first phase of REACH in 15 districts we have covered. We're planning for the second phase of REACH in the same with the same partner hospital in the same locations, so that some of the important point like sustainability and then things like that can be addressed in the second phase. This is some key highlights, like 4.7 million kids were screened in 3 years, 136,000 prescriptions were given, close to 100,000 spectacles were given in 3 years. Part of the data also we have analyzed, like 10,000 schools were covered. If we look at the entire program coverage, 84% were rural school and then 16% urban school, and 77% government school and then 23% private schools. So that way, the coverage-wise, rural and then government schools were covered so that underserved population can be served to this particular program. Enrolled versus screen. This coverage also we looked at, 90% of the enrolled kids were screened during the program. Identified versus examined. I think during primary screening, the number of kids was identified for secondary evaluation. Out of that, close to 80% children were screened. This 20% gap, basically, initially when we have the program, we have the primary screening and then secondary evaluation in 2 different days. Because of that, there are dropouts for the secondary evaluation or secondary examination day. So later on, looking at time to time the data, we have changed the strategy to combine those secondary and then primary and secondary evaluation together in the program. The interesting fact like this, near about 45,000 existing spectacle users were there in this school, but near about more than 50% actually children who were wearing spectacle advised to give a new pair of spectacle because of change of power. Then from that group in the secondary evaluation group, 21% needed other evaluations and surgeries and things like that. So every year, that is an important thing that until unless we create a system where we go back to the school again and then look at these children, it'll be very difficult to resolve this issue of refractive error completely in the school going kids. In terms of compliance, we have completed 60. So in our data shows that 66% children, when we've gone back to the school to look at compliance at 3 months, there were 66% children were wearing spectacles. 56% girls and then 44% boys were compliant, but there was no significant difference between urban, rural, and then school type like private and public. 57% children aged between 10 to 14 were compliant, but in the higher age group like 15 to 18, our data shows that only 27% children were wearing spectacles. This is where we need to do some strategies in future so that why they are not wearing spectacles. We have the data, we need to do the analysis and then see that what happened during this age, in this age group, why they are not interested in wearing spectacles. This is not even prevalence, but with our data, we see that it is 2.5% were overall refractive error and uncorrected refractive error 1.75, which is showing little lower. And the prevalence was similar in both the genders. I just wanted to close my presentation by showing this impact tree. So if you don't give a pair of spectacle to a kid in the right time, I think probably the child is going to be drop out from the school, excluded by the peers, I think dependent for daily living, denied opportunity for work, continues to lead life in poverty. But if the pair of spectacle in time helps the child to remain in the school, enjoy their livelihood, regains independence and then confidence, earns living and then supports family, and then breaks the cycle of poverty. So it's basically more than a vision, it's life. So Orbis work actually intends to have a kind of a nation where no child need necessarily go blind or visually impaired. Thank you so much for your patient hearing.
Thank you so much, Dr. Rishiraj. I think the last slide was, just said it all, where we need to move forward. Thank you very much for your presentation. I would like to thank all the speakers of the webinar for coming at such a short notice and for participating in it and for giving such useful insights. And now we go on to the second part of the webinar, which is the ophthalmic photography competition results. And this is just to show that we had ophthalmic categories of color fundus, corneal topography, slit lamp topography, external photography, and endothelial cell layer photography analysis and optic nerve head analysis. and total of 438 submissions were obtained. And we had a panel of judges who really worked hard to scan these photographs, and we have some of them with us here. Can we have the video, please, Sunil? Sunil, Rajesh, Sunil, can you just play the video? Thank you, Sunil. Rajesh, can we now, I would now first request the judges who are with us today to say a few words about the contest. So I think, Dr. Tushar, would you like to comment on the contest?
Thank you, madam. It's always a pleasure to be part of this activity. I like photography personally, and I liked this concept, and there were a lot of good entries. It's good to see participation from all over the country, and it was actually a difficult job to select the winning photographs. There were many which could have won, but the competition was quite tough. And I really, I'm not aware of the results themselves, because this was done separately. All the judges have graded the photographs separately. So I'm as keen as everyone else to look at the results and see if my choices are there in the top.
Thank you so much, Tushar. I think when you'll see we collated all of them and just averaged out in the end from all the judges. Dr. Paras, if you're there, can you give your comments? Dr. Paras Mehta?
Yeah, actually. Yes, I mean, it was very interesting. And thank you, Dr. Namrata Sharma, for involving me in this event every year, kind of. And it was very interesting to look at so many images in a toto kind of. Photography always interests us in looking at various aspects of it. Some aspects would be like clarity of the picture, how the person has captured it, and I mean, what particular disease process has been captured, and all those points were I mean, looked into by the judges. And that was really interesting to kind of I mean, sort out those pictures and put it into a like categorize them. But obviously, I mean, we don't know what is the ultimate outcome, as Dr. Tushar rightly said. So I'm also interested in looking at what exactly is I mean, selected eventually, and who are the winners. And it was really interesting to be part of it.
Thank you, Paras. And then we have the youngest of our judges, Dr. Praful Maharana. Praful, would you like to comment on the photographs that you received?
Thank you, AIOS, for giving me this opportunity. I don't know, there is some issue with my camera, I guess, so I am looking like a zombie in this webinar. So,
an award for this. Award for this.
Photography competition and your own video is coming improperly.
तुषार उसके लिए award मिलेगा.
Okay. Yes, I deserve some award for this. Okay, so coming to
your points have to be deducted.
Can you stop your background? I think your image will be okay.
It's fine. I'll just speak few words about this. First of all, thank you, AIOS. Secondly, I would like to congratulate all the participants for participating in this. But one thing that I would request everyone for next year's photography is, please save the photograph that you have experienced through this difficult COVID times, because I was expecting some photograph at least of this, but I couldn't see any of them. But I would request everyone to participate and also show some photograph like that only. And where the competition was tough, and there were a lot of photographs which even I was confused to whom to choose the winner. But luckily there are 4 other judges to blame if something goes wrong. So thank you, AIOS, and I'm also as eager as other judges and participants to see who all are the winner. Thank you, AIOS.
So we have actually blinded the photographs. We had give them numbers. We did not tell whose photographs they were, and we did not tell the institution also. And at the end, we just averaged out all of them. Dr. Shobit Chawla, I think, will join soon, but he's not here. And Dr. Manish Nagpal had a commitment, so could not join. So now I would request Dr. Rajesh to please put up the PowerPoint. The winner of the first prize is the iPhone. The second prize is a iPad, and there are other appreciation prizes of rupees 5,000 each. So Rajesh, can you announce?
Yeah, once again, I would like to thank all the judges, Dr. Shobit Chawla, Dr. Tushar Agarwal, Dr. Manish, Dr. Paras, Dr. Praful Maharana. And we have a few appreciation awards, and then one first prize and one runners-up or the second prize. So I would like to announce a few appreciation awards first. So the first of the appreciation awards goes to Dr. Abhimanyu Sharma in the category of external photography, and the title is Warm Hole. So congratulations, Dr. Abhimanyu Sharma, for this.
Rajesh, maybe you can tell the number of entries we got. I think there was a phenomenal number of entries.
Yeah.
436.
438.
430 something.
438.
So is that a record of sorts?
This is the highest we've got, sir.
Highest, yeah.
Third year we have held this competition, and this is in call again. IAPB calls for it, so we've done it, and this is the highest ever.
Yeah.
Next of the appreciation awards goes to Dr. Chintan Dedia in the category of color fundus photography, and the title is CRAO with cherry red spot with sclerosis of arterioles.
So this is just to highlight that this is an alphabetical order that they have been put.
Yeah.
They have not been put according to whatever merit, because these are all graded at the same level.
Another appreciation award goes to Dr. Debashish Dubey of Sankara Eye Hospital, Bangalore, in the category of color fundus photography, and the title is the Retinal Shield Peripapillary CHRPE. The next appreciation award goes to Dr. Hridaya Mohan from Arvind Eye Hospital, Coimbatore, and in the category of external photography, and the title is Iris Flower. Nice looking flower, we can see that. Another appreciation award goes to Dr. I. Satyanarayan Murthy in the category of external photography. Another appreciation award goes to Dr. Jagdeep Kakadia in the category of external photography, and the title is Octopus in Eye. Dr. Namta, would you like to announce the remaining appreciation awards?
So the appreciation award was given to Dr. Lekha T in the category of color fundus photography. The title is CMV retinitis with frosted branch uveitis. And all these appreciation awards are going to get a cash award of rupees 5,000 each. We would like to thank Sun Pharma for sponsoring all the awards. Next is appreciation award to Dr. Minakshi Sandhu in the category color fundus photography, and the title is optic nerve avulsion. Appreciation award again to Dr. Nikita Sonavane from Arvind Eye Hospital in the category color fundus photography, and the title is decompression retinopathy with 360 degrees circumferential vascular occlusion. The next appreciation award to Dr. Rahul Bafna from RP Center Ames in the category of again external photography, and the title is spider web in the eye, persistent pupillary membrane. Another appreciation award to Dr. Ravikant Bamotra in the category color fundus photography. The title is retinochoroidal hemangioma involving the disc. Appreciation award to Dr. Ravija Kataria from MNJ Institute of Ophthalmology, Civil Hospital, Ahmedabad. The category is external photography, and the title is Enlighten. And I don't know what Alcon will have to say to this enlighten, as opposed to the panoptics enlighten that they have. Appreciation award to Dr. Richa Dhiman in the category slit lamp photography. The title is IOL haptic touching the cornea. And appreciation award to Dr. Rohit Dureja, LV Prasad Eye Institute, GMRV Campus, Vishakhapatnam, category slit lamp photography, and the title is Dancing Worm in the Anterior Chamber. I think we always get worms and in the anterior chamber in the eye as a bodies. Another appreciation award to Dr. Shwashanti Mohan, slit lamp photography, polyfloria, persistent pupillary membrane causing polychloria in a floral pattern. And I think this is last of the appreciation award to Dr. Santosh Bhide from Bhide Eye Clinic, Pune, on macular abscess, patient treated, and there were a set of photos after treatment as well. So congratulations to all the winners of the appreciation award. And for the second place, which is an iPad, I would request Dr. Lalit Verma, the Vice President of AIOS, to please announce the award.
You see, it's a phenomenal, action which, all of AIOS has undertaken. And I am sure what Tushar was saying is so difficult to judge. 438 entries to get one second prize is unjust, actually. So whatever, you see, in any case, iPad has to be given. So I'm very happy to announce that Dr. Jagdish Shah from Mumbai wins this second prize and gets an iPad. And the title is My Ordeal by Flight. And that is the, you see that patient with ant in her eye traveled from Chicago to Mumbai in the flight, I think. I presume that Chicago ke saath hi Mumbai tak pahunch gaya wo.
In the COVID times also, sir.
In the COVID times also.
When humans can't travel, the ants can.
Lalit, it says it's a patient is a male and it says 56 female, her eye traveled.
Yeah. So that I leave it to the wisdom of judges. But in any case, this photo is, quite catchy and reveals quite a bit. So congratulations, Jagdish, for winning this iPad. Thanks to AIOS and the entire team of judges also.
And thanks to Sun Pharma, sir, for sponsoring the prizes. Yeah. And we would like the President AIOS, All India Ophthalmological Society, to announce the winner of the photographic competition for 2020 on World Sight Day, and that is?
Great. And the first prize goes to Dr. Anugraha Balamuragaram from Mahatma Eye Hospital, Trichy. And this is on the category of fundus photography and the retinal fireworks of flecked retina syndrome. It's really a great picture on autofluorescence and the color fundus. I think congratulations, Dr. Anugraha, and I think the contest, whatever pictures that have been shown here is really of a phenomenal caliber. And during this COVID times, we have discovered so much of talent amongst the ophthalmologists apart or outside of ophthalmology. So let's keep going and let's have these things more often. And congratulations and thanks, Dr. Namrata and Rajesh and all the judges, Shobit, Tushar, Dr. Nagpal, Praful, Paras for helping us in doing this. I know it was a mammoth task, but I think we all enjoyed the pictures which were there, and they will be trendsetters for still better pictures to come in the next years. Congratulations to all the winners and all those who contributed their pictures for this competition.
So thank you so much, sir. And it is now, we are now coming to a close to this webinar. And I would like to thank everybody who helped to make this happen. All our speakers of the previous section from representing all the various organizations, including the Ministry of Health and Family Welfare, Dr. Praveen, especially for coordinating from RP Center, Orbis International, Vision 2020. I would like to thank all of them for being here on the World Sight Day, which is so auspicious, for celebrating the World Sight Day, for celebrating the figures that we have, we are nearly there. And if we march like this together, I think we can move forwards. And like I said even yesterday, I think it is not about AIOS, it is about all ophthalmologists, whether they are members or non-members. Each one of them have contributed to these figures and to the march forward. Would also like to thank all the judges who have taken out time to see these photographs, to mark these photographs. All of them are great photographers in their own fields, and I know all of them personally for their great photographs. Would also like to thank Sun Pharma for sponsoring this webinar and for sponsoring the awards, and would like to thank the audiovisual team who have worked quite a lot on this, especially for the photography part, Mr. Kripal Rana, Ms. Rakhi, and Mr. Sunil with the audiovisuals. Again, we would like to thank Professor Mahipal Sachdev, our president, who's very encouraging and under whose guidance we continue to do these events, and the entire governing council, who's so supportive and who was here today to grace this occasion on the World Sight Day. Thank you, everyone.
Thank you, madam.
Sure.
Thank you,
Thank
everyone.
you.
Thank you.
Thank you, ma'am.